So hello, everybody. My name is Adam Chirinas from Bluestream Health, and I want to welcome you to today's webinar, Making On-Demand Care More Accessible to More Patients. Brian, if you go to the next slide, please. Great. So we have three terrific speakers for you today. My colleague, Brian Yarnell, who is the founder and president of Bluestream Health. And we're so privileged and delighted to also have our clients here from New York Health Hospital, Mr. Erfan Karim, who is the executive director of the ExpressCare service line, and his colleague, Christopher Philippou, who's the chief operating officer of ExpressCare as well. If you go to the next page, please, Brian. Yeah, we'll talk about today's the agenda. So what we're going to be talking about today is the shift to on-demand access to care. And we're going to be diving in deep on how you can do this, enabling a multi-channel approach. And one of the key issues that comes up with that is how do you scale your operations? And we're going to talk about how you do that. And Brian will be talking about the approach that we take with that. And Erfan and Chris will be going into detail and be here to answer your questions about how they've done an extraordinary job across New York City and now actually being deployed across New York State. This leads to some great benefits. It reduces hospitalizations, reduces ambulance transports and ED visits. And as I said, we're going to be highlighting how this is working in New York Health Hospitals. You should be able to access the Q&A function. So as you've got questions, put them in there and I'm going to moderate them. But we expect this presentation will last about 20-30 minutes, and then we'll have time for Q&A at the end. But put your questions in as you occur to them, and I'll try to get as many of them answered as possible. So with that, I'm going to switch off my video and audio and hand over to my colleague, Brian.
All right, thank you, Adam, and welcome everybody. Like Adam said, we want to try to make this a dialogue. Obviously, it's tough when we're going through a presentation like this. So we'll try to be a little bit brief and make sure we leave some opportunities for Q&A at the end. To Chris and Erfan, I'll start out the presentation and talk a little bit about some of these agenda points. If you guys do want to jump in, just wave at me or just jump in. Like Adam said, the agenda here is really focused on some considerations on why people are shifting to on-demand care and, of course, how to respond to that shift appropriately in terms of delivering the right technology and the right clinical programs. We're not going to make this a sales pitch and give you a demo of what we do. We're going to try to keep it really high level and objective. Obviously, if you guys want more information, just reach out to us. Okay, so on-demand care, as you guys no doubt have noticed, is becoming the new normal. And there's a lot of facets to it, but at the end of the day, it really comes down to consumer and patient expectations. And, on the right, we have our little caricature of the American consumer. The motto of the consumer has always been, I know what I want and I want it now. What's changed is that post-COVID-19, consumers are really educated that on-demand care and access to virtual care is an option. In the past, it was kind of a novelty or something that had a lot of hurdles to get to. Virtually every patient has been exposed to telehealth, to virtual care, and probably had a pretty good experience. So at this point, it's what people demand, and not just the consumers and patients, but care providers as well. We saw a little bit of friction initially about adopting some of these virtual technologies, but care providers, the clinical folks, and the patients have all gotten used to being able to have these interactions with a little bit less friction and reducing the needs for appointment scheduling and transport. And what's interesting here is, you've seen some on-demand models that didn't stick, that effectively let a patient demand a visit and get a call back or an appointment 3 days later. And that's not really on demand, right? When we talk about on demand, we're talking about you click a button, you pick up a phone, you log into your portal, and you have access to healthcare where you need it, when you need it. And the interesting thing that's come out of these two first bullet points is that there are plenty of non-traditional people in the space, people like Amazon, people like Walmart, CVS now, that are happy to provide that experience for your consumers. So, it's a little bit of a wake-up call that if you're not willing or able to engage these folks how they'd like to be engaged, somebody else is going to. And there's some real implications down the road for you if you can't engage people in the way they expect to be. So financial, of course, you want to retain your patient population. For folks like Chris and Erfan, there's a big geography called New York City, and there's lots of people in that geography, and there's lots of care options. And you want to maintain that population, build a long-term relationship with your consumers. In the marketing world, it's called brand equity, right? You want people to keep coming back to your organization and make it easy for them. And of course, you want to cast a wide net and bring new patients, new consumers in that front door. And there will be competition for those eyeballs, for those relationships, even more so going forward. And ultimately, what most of us are concerned about is improving the quality of the care those consumers and patients receive. And that comes down to continuity of care, right? A lot of consumers, I get friends asking me, how do I get access to virtual care? And I'll ask them, who's your healthcare provider? What network are you in? And they just don't know, which is concerning. Right? You want people to have this continuity of care where no matter what front door you walk through, what resources you pursue, you're getting a consistent, persistent relationship with your care providers. And you want to, wherever possible, keep those folks from progressing to the point where they're utilizing acute care if you can. So the way that we do that, or the way that we think of that, is really putting together a multi-channel strategy for putting these front doors or these different entry points into healthcare where patients expect them, right? So we're really talking about casting a wide net in terms of how you engage with patients, where those patients come into that funnel, and ultimately wind up in front of a clinician or in front of a care provider. So that's got to be done in a way that accommodates patients of all technical abilities, right? You can't be making people download apps. You can't make this overly complicated. And at the end of the day, you've got to make it simple enough that people like my parents who may not have a smartphone can get in those front doors as well. You've got to intercept patients where they are, right? There's this kind of old-fashioned notion of sending patients to download an app or sending them into a patient portal. It's disruptive and not in a good way. Right? You want to have entry points into your healthcare system, into your clinical system, wherever patients are, whether that's in a subway, looking at a subway ad, whether that's in their patient portal, or whether that's just a consumer-facing website that is really friendly and really easy. And if you do these things effectively, you are preventing that leakage, because ultimately consumers have choice. And if they're Googling where to get healthcare, you'd better be at the top, because if you're not, your competition will be. And when you do that, supporting these low literacy folks, people that don't speak English, people that are hard of hearing, people that have low health literacy, you've got to be able to potentially put together a stratified approach in terms of how you intercept these folks and how you shepherd them into those visits and the follow-up. And we've got this bubble on the side called integrations. It may not be what you think, right? Typically, people think of integrations as, how do we move data into an EHR? Certainly we do that, but when we think about integrations, we're talking about leveraging partnerships and business integrations and relationship integrations to present entry points into healthcare delivery at partner organizations or within systems they may already be using. A great example is what happens when a fire truck shows up at your house? Can you get direct access to a virtual visit? Or what happens if you're on your insurance provider's website and you want to talk to a doctor? Can you make that process seamless? So that's what we think about in terms of integrations here. And speaking of integrations, as much as we kind of hate to admit it, telephone's a big one, right? We see a large number of patients, especially in programs like COVID Test to Treat, where the first point of entry into the healthcare system is the telephone. And for some folks, that's the only point of entry they'll ever use. But we make an earnest effort to engage those populations, to treat them the same as anyone else, and wherever possible, bring them into the video realm so that you can treat them better, have better outcomes, And ultimately, in some situations, you actually get a better reimbursement rate for up converting those telephone-based visits into video. So, consumer experience is key, and hopefully that's kind of resounding at what I'm talking about. And from our standpoint, later on in the presentation, Chris and Erfan will talk about something called Net Promoter Score. How likely is a consumer to recommend this service to their friends, to their colleagues? And as much as I'd like to say it's all about great technology, the reality is it's not. The technology's got to be simple. It's got to be seamless. I put some tiny little screenshots on the right side where you can see things like a text message invite, a QR code to scan to get into a visit, consent forms in the patient's native language. You've got to adapt these things and think about who your target audience is and make sure they speak to your audience. You've got to have not so complicated pieces for the late adopters and support for people that may speak a different language or may be visually or hearing impaired. But there's a point where technology ends and people take over. And a big factor in things like that Net Promoter Score, it's really about, how professional are you as an entity when you're virtually engaging with a patient population? If you've got a really great white glove brick and mortar service, you better have a really great white glove virtual service. And that comes down to things like short wait times. In my experience, looking across the data, once you make a patient wait more than 3 minutes, you may lose that patient. You've got to have really professionally well-educated folks that are doing intake triage and collecting appropriate information that the clinicians use. So this last bullet point is kind of funny, but who hasn't been on the phone with people like the cable company or like the phone company, and it drives you insane that you've got to keep telling people the same thing over and over and over again. It's really important that at that first point of entry, you collect the important information and pass it on seamlessly down that chain of clinical operations so that it's smooth and it's frankly just a pleasant experience for the consumers. So when we talk about creating scalable approaches to do this, right? I mean, when you think of an on-demand approach, if you're dealing with 5, 10, 20 patients, it's not so difficult to imagine how you might work with these people. But when you think about the scale that people like Chris and Erfan are dealing with, we're talking about thousands or tens of thousands of encounters a month. And when you start thinking about that scale, you've really got to balance the consumer experience, the provider experience, and how do you manage this throughput appropriately? So this is where you start to see the split between enabling technology like we provide and clinical operations like Chris and Erfan provide. So from a technical standpoint, we've got the tools to put good, smart triage in place. And that's going to involve things like automation, routing people to the right queue or the right provider based on things like licensing, time of day, resource availability, giving providers the situational awareness to do their jobs, understand what does that queue look like? Where are patients coming from? Are there other urgent patients that might be at the top of the queue, like that example in the screenshot? And putting together the complex workflows that start to feel like a brick and mortar experience, but are delivered virtually. But once you've got all these tools, they're just tools, right? You need practitioners to actually use those tools and deliver. And that's where the clinical operations comes in. And the goal of that clinical operations group is delivering those fast response times, professional interactions with patients, and ultimately patient outcomes that have an impact on your finances and on the patient's quality of lives. So unless you guys, Chris and Erfan, have anything to add, I'll kind of hand the reins over to you to talk about how that happens.
Yeah, and can we go back to the previous slide? I think, Brian, this slide is part of the takeaway, and the next couple of slides kind of iterates on what that really means. It's technology versus operations, but the key is to make it technology-involved operation and to make it seamless, right? You want to enable technology to aid your patients and your providers to have the best experience possible for you to have clinical success and the best clinical outcomes that are possible through this interaction. Now, not everything can be virtualized. So it's a blended model that us at New York City Health and Hospital Virtual ExpressCares have, where anything that could be done virtually is completed in a clinical evaluation fashion virtually. But if we require in-person setting evaluations, then we bring the patient in for appropriate care. Going into the next slide, so that patient experience and provider experience, you have to reimagine. What does that look like? And how do you make it so that patients love using your service, but just as much your providers love using the service? If it's too complicated for any one of those groups, it's not going to work. If the education required for any one of those groups, patients or providers, is too much of a heavy burden, too much friction in there, the system is not going to work and it's not going to be efficient. Really, at the center of all of this is imagination. You have to break free of the mold that healthcare typically functions in. And COVID allowed us to do that over the last few years, and it enabled us to really build new models of care and test models of care using our imagination and innovation. And that doesn't necessarily mean the care is less safe. That doesn't mean taking more risk. That means just challenging the norms and thinking about the patient care experience and the provider experience in interacting with patients. So for us, that started with, how do we enable technology to get the patient to the provider as soon as we can, right? And that meant decreasing the amount of burden we had in documentation for our patients. We don't need to collect 5 pages of information before the patient ever gets to a provider. Some of those patients don't ever end up because that burden is too much. Brian mentions his parents, similar to my parents, like first-generation immigrants in New York City. English is not their first language, and they would not be able to navigate the traditional healthcare landscape. But with Brian's help from the technology perspective and our imagination at Health and Hospitals, we're able to build something that anyone, whether they're 90 years old or they're 18 years old, are able to leverage what's appropriate for them to get that care and connect to a provider group that's able to provide definitive solutions for the patient. And how do we provide that definitive solution? That starts with clinical protocols. So we protocolize every aspect of the care and the experience so that our providers are ready. Our providers know what to do. It's been vetted and it's clinically safe, right? This is with hundreds of thousands of visits that we're able to now test our protocols, adapt and change and continuously evolve to meet the needs of the patients and make sure our providers and our staff are ready for anything that comes through their doors, right? In a healthcare setting, in person, you have many tools that you might not have through a telehealth visit, right? You might not be able to get all the information you need, including biometric data, readily, because you might be on a telephone call, or you might be in a situation that it's not possible and the patient is isolating, so on and so forth. But you still need to provide the best clinical service you can for the patient and take care of them, and then determine when they need to come into in-person setting. So those clinical protocols are step 1. Step 2 is training and education. So you have to take that clinical protocol and train your staff and educate your staff how to utilize those protocols and the technology to give the best care possible. The education and training also goes towards your patients, right? You have to make it as easy as possible for patients to access. For us, it's 1 click or a couple of clicks to get to a visit. The least amount of information the patient needs to provide for us to get started, that's what we do, right? And we also did the telephone service to make it easy for the patient. And then educating our providers on the patient experience and the journey. So if a patient is stuck in any particular step and they have connected with us, our providers know exactly what that looks like, what that feels like, and they themselves are able to navigate and educate the patients for that visit and future visits, right? These becomes important for conversions. So when you go from audio to video and so on and so forth, those are important for clinical and financial reasons. We're able to do so because there is that training and education level and comfort that the providers and the patients have in the system in itself. I think much of all of the work we do in virtual care comes down to comfort and replicability. And that's what leads to our success as well as efficiency in delivering the service itself. Staffing itself is a big concern. And I think staffing and data-informed decision-making come hand in hand in many ways. You want to figure out what's the optimal staff that's able to provide the service? What is the scenario calling for? A 911 patient that is transferred over telephone does not need to go through a registration staff member first in order to get the best care possible and receive definitive care, right? Time is of the essence, and we want to make sure we're able to work with the 911 system or with the patient to get the information without having to engage the provider directly and go through a wait time or increase in steps. So we could integrate directly into the system. So this is the CAD system in New York, and get the information readily, and it just shows up on the screen. Or we could work with others, payers, for example, to get that information and make this seamless. So where the provider is the first person seeing your patient. And to a patient, that is really important, right? That's the thing they care about the most, is the experience they get with the provider. That's what they're here for. And so from a staffing perspective, you have to have interchangeable staff that's able to deal with all these different types of patient using the clinical protocols and their training, and then make a decision on what needs to happen on the patient. From an administrative perspective, it's my job to have the data available, right? Take the technological data, the customer experience data, the patient experience data, as well as the provider experience data, put it all together into hour by hour grid for the month and the week and the day to figure out what is the optimal amount of staff I need to keep it to that less than 3 minutes, to make sure that we're able to address the concerns of the patients, but also provide clinically safe care. Going on to the next screen. Chris, I'm going to hand it off to you for the next couple of slides, and then I'll come back.
Okay, great. So in terms of creating a successful program, I'm going to go through a few areas that you need to think through as considerations. So in terms of program prioritization, it's critical that you take projects that can potentially grow to scale and do so quickly, right? We shouldn't focus on initiatives that will end up with low volume or will not effectively serve the patient population. So it's critical, especially given that you're going to use political, operational, and financial capital to be able to launch any telehealth or hybrid model, that you need to do so with a speed that will get you to where you need to be to sustain the program long term, right? So growing stepwise, Rome was not built in a day, neither was virtual ExpressCare. While we're now over 100,000 patients, initially the volume growth was not as quick as it has become today. So in general, you have to recognize that you will test and scale, and that you will not start with the perfect program to begin with, but build something and refine through performance improvement and quality improvement to get to that final state. And then with respect to financial goals, we don't just look at financial, but we also look at access, quality, and the patient and provider experience. So Erfan laid out that we have dashboards to track these different indicators, but it's important to think of this as both process and outcome, right? Where we're tracking specific indicators based on use case, but as a service overall, so that we can understand the health of the service and the work that we're doing, as well as that we understand that providers and patients are experiencing the best service that we can offer. That's something that we're managing day to day, but we also take a longer view as we guide the service sustainably into the future. Next slide, please. Staffing consideration. Staff is really the lifeblood of the service. If you are not staffed optimally based on the data, right? We take a data-informed approach. We can't do everything based solely on the data. We need to take into account market and external factors in projecting future volumes and staffing needs. But it's critical because if we overstaff, we can't really deliver this service sustainably, and we also burn through capital in other areas much quicker than we would if we staffed accurately, right? So things that we look at, as Erfan said, we have, we understand the volume, demand by time of day, day of the week, and based on different factors and use cases. And we take that into account, as well as market trends. Whether, and COVID has obviously been a huge factor in how we think of staffing, but there are other changes in the market that we have to staff to, and we think of coverage by time of day and day of week. Level of specialization. So the staff is comprised of both clinical and non-clinical and different specialties within clinical. And we look at those separately, right? The non-clinical supports all of the different clinical services, and the services are, scalable, and we take into account the overall volume demand and projected demand in terms of which specialties and types of staff we're staffing at any point in time. And then, generally we think of how we can best use staff and leverage them to serve multiple use cases. And that's what Brian is talking about with cross-functional roles. It's critical that when you're, you're building your service, you take into account the different abilities and ways that your staff can fit into roles that you need to meet that customer experience and patient experience. And an example, would be how you use your, you could use your agent or clerical staff for a variety of different reasons. And you can also think about how you perform follow-up, if any, from your service. And then finally, the how many butts in the seat, crude way to think of it, but ultimately we do need to think about how much staff we need to actually deliver the service that we're going to deliver and what we promised in that initial proposal. And that's something that you're going to have to model out as part of starting a service, but then it's also something that you're going to have to regularly review to maintain a successful service. Next slide, and I'll pass it back to Erfan.
So looking at, I see there are questions in the Q&A, we'll get to those, but what did this mean for ExpressCare overall, right? ExpressCare is part of New York City Health and Hospital, largest public health system in the country. So we're a health system, and we're able to leverage some of that infrastructure to build out these services. But ExpressCare was the first one to go beyond the city of New York into outside of the 5 boroughs and into the New York State, all of New York State, and serve it. We were actually selected by Department of Health as the COVID therapeutic service line, and we continue to serve that function through this winter and henceforth. What we're proud of is the it's actually 95% patient satisfaction, Brian, and 80% net promoter score. As Brian mentioned, net promoter score is if the patient is willing to tell their friends, family members, and others to utilize the service. And we collect this information not only through the post-survey screen on our telemedicine platform, Bluestream, but we're also sending out surveys from Pescani and others, and it's been validated. And this is really great. It might not, 80% seem like low in terms of what it is, but from a net promoter score, it goes from -100 to 100, and typically healthcare is in the 40s. We are at 80, and it's been sustained over tens of thousands of visits. In terms of the ability to scale, so going back to the protocolized solution, training, and all of these things, and putting it together with a technology that is able to respond to any situation that comes in, right? So we scale in a time-sensitive way for use cases that included COVID therapeutics for infusions, highly complex operations. We were really successful in New York City and able to provide this service in a very coordinated fashion, right? Talk to a patient, give them the service, make sure they're eligible, find which location they're closest to, give them a taxi ride, order an Uber ride, and get them to get the infusion the same day or within hours. For Paxlovids, we're able to, if a patient tests positive, they come to us, they call us, they come in through the web, we're able to evaluate them, make sure they're eligible, and send them a script or deliver the medicine same day. within the afternoon, the patient is taking the medication. And really, it's a combination of hybrid, telehealth and in-person settings. Decreasing avoidable utilization through 911 and EMS system integration. So we work closely with FDNY, who runs the EMS system in New York City, and we take direct transfers, low acuity calls. We protocolize those visits and keep most of those patients at home when it's indicated. If that patient needs to be seen in person, and it's an emergency, of course, we're able to deploy an ambulance right away and get the patient the care they need and bring them to any ED, the closest ED to them. And if that patient could wait, it's not an emergent situation, but they do need to be seen in person, we're able to once again offer a Uber ride or a cab ride and bring the patient into an in-person setting so that they're able to get the care that they need. Lastly, partnerships for growth and direct integration. So we're integrated with the payer and we work with our Department of Homeless Services. We're integrated into shelters throughout the system and really working through kiosk and other models to directly get patients the care that they need and build unique partnerships to make this a reliable solution for both the patients and other partners that we have throughout the city. So that wraps up like what ExpressCare has done. In terms of raw numbers, we're looking at almost 120,000 visits at this point in time over the last year and a half, 2 years. We're looking at, for Paxlovid, over 40,000 encounters, and we're the largest provider of Paxlovid in New York State, individual provider. And that's really a testament to the technology and the provider base coming together to build something incredible. In terms of the model that we use, it's one of the questions I see in the Q&A. Does payers, and in this case, particular payers, accept this as in-service or in-network? I think there's many people here from multiple states. That depends on payer to payer and the contracts that they have. Emblem, I'm familiar with in New York, of course, they accept it. I myself have Emblem, and it's an in-network service. We run this as an urgent care service, both from a behavioral health and a medical perspective, and that allows us to be included in most plans and is covered by most plans. Now that will depend on contracts that each institution signs with individuals directly. We also work with the large payer in New York City that has defined this service as a benefit so that the patients don't have any copays and they come to us directly from the payer and we're able to provide the service at various times of need for the patient, 24/7, 365. In terms of firewalls between operations and clinical practice of medicine, we're a health system, and this is an integrated service, right? So we're not necessarily, in terms of the practice itself, it's driven by the patient. The patient asks for the encounter, and we're able to serve them. Now, once the patient is served and we're able to leverage the data as part of the clinical service, both from an administrative perspective and a clinical perspective, to understand what's happening to drive better care from a quality perspective. And we don't run afoul with any of the legal or medical legal issues that potentially is concerning to others. We really work together with our legal teams, and we're Joint Commission certified. We've gone through surveys. We're really on the up and up when it comes to all the services we're providing, and there's no real conflict on that front.
Yeah, one thing to add on that, Erfan, is that we work for a healthcare system, right? So we work for New York City Health Hospitals. So I think the corporate practice of medicine is more around, non-medical individuals or companies. I think in our case, I think you'd have to seek any other legal advice for that question if that's specific to you. But this is a healthcare organization, and and that's we follow all local, state, and federal laws, and we seek our legal counsel where needed. But we are a certified provider and a healthcare system. I think we're following regulations at the local, state, and federal level.
In terms of, do we employ clinical staff directly? Yes. So in this presentation, you're looking at the technology front, which is Bluestream Health, but we are a medical provider. So all of our staff are within our span of control, and we work together and partner with our clinical staff to build the program in conjunction to serve our patients. And in terms of that nuance from a clinical organization perspective, it's really important to provide the best care possible for the patient. And it's really important to attract staff members that are suitable for telehealth and is able to work together to make sure that we provide care to the patient that's appropriate. In terms of remote patient monitoring, great questions. So we do remote patient monitoring during COVID. We did monitoring for COVID throughout COVID, and any patient that escalated, they were escalated through the system to one of our providers for urgent care visits. We're also working with various things. So heart failure is one you could think about, and there's many others, diabetes, so on and so forth, this is relevant for. I think anything that is remote patient monitoring comes down to the same model that we're providing here, which is on-demand care with the data integration and or additional data points that help make definitive care possible. So if a patient, for example, in a remote patient monitoring platform or system is able to indicate that they have some concern, then we have our staff available 24/7, a provider that's able to interpret that, do an assessment, and determine what is needed for the patient. And most times that is not an emergency room visit. We also work closely with our ACO, so patients that require or may think they require immediate care and the ED visit because they stubbed their toe in the middle of the night, don't necessarily need to be seen in the ED. They could talk to a provider through this telehealth platform, and we could keep them safe at home and monitor them so that they're not unnecessarily going to the ED and staying there for the next few days because these are complex elderly patients.
One thing I'll add while people are typing questions is, Bluestream Health, we're a technology platform. So there's some questions around, do you provide providers? I don't know if that was directed at us or New York City Health and Hospitals, but I want to be clear, there is, 100% clarity that Bluestream Health does not provide healthcare providers. We are not a healthcare system in any way. We're just the plumbing, right? We provide the technology for groups like New York City Health and Hospitals and others to create platforms like this. And then we provide, the infrastructure, the security, the compliance to route the patients to the right providers based on licensing, credentialing, whatever other criteria. But in no instances are we ever actually taking any calls.
In terms of how do we handle EHR data exchange with other providers? So there's many things that happen there, right? It's complicated and simple at the same time. Adam, you got to stop taking away my questions.
Oh, sorry. Here we go. Here you go.
So in terms of the EHR, right? Everything is in Epic. We're an Epic shop. So there is Epic everywhere, and we're able to share the data for anyone that has Epic, right? There's also, RIOs and regional health sharing networks that disseminate the information. We also work with patients. Patients get an after visit summary. So they're able to take the information, access it, and share with their providers directly. So that enables us to give the power back to the patient to share the information. Lastly, there are other pings and networks that's built in. And as you build partnerships, whether it's Bluestream Health or through EHR, you could build robust partnerships that transact data to make sure that we're able to help patients get the service they need, and it's from the service provider they choose, right? So one day they could come to us because we have this great service, but they might locally get their service elsewhere, right? One great example is one of our boroughs. We partner with another large hospital system where we would do the evaluation and they would get the infusion near their home in that particular hospital in that borough. And we're able to do an integration directly by working together with both the borough hall as well as the health system's leadership to make that happen technologically as well as from an operations perspective.
Great. Well, thank you. I don't see any additional questions. Please pop them in. I'm going to kind of assume that I think we're probably done with the questions. As we wrap up, I just wanted to ask the three panelists for closing closing comments, and maybe to help you with a closing comment is if you could give the audience one piece of advice for going through a similar journey, what would that advice be? And I think I'll start with Brian, put him on the spot first, and then we'll go Chris, then Erfan.
I think, when we talk with people about our technology platform and what they're trying to do out in the world, we keep hearing this theme that, this sounds amazing, but how do I do all of this stuff? Because it's so big, so comprehensive. So, the biggest advice I would say is really think about it stepwise, and how do you implement programs that have an impact immediately that you can staff without it being dilutive. You can't put 27 doctors in a call center and hope somebody calls. You've got to figure out how do you implement programs that have an immediate impact on your bottom line, on patient outcomes. Start from there and get it out the door quickly. We see people with kind of analysis paralysis that want to boil the ocean, and you're 24 months in and you haven't done anything. So pick a program, pick something that has ROI that's measurable, that you can get out the door quickly, and start there, and then things will grow.
Yeah, I think from my perspective, it's, patients and consumers have expectations that are now, well ingrained in what healthcare should be. So I think, someone did, bring up a question around how do we know what a customer wants? I think there have been a range of different surveys in the industry and how patients feel about getting in-person care as the starting point. And I think all the research points to expectations of a hybrid model with a virtual first approach. We're giving, and we've talked about some of the considerations of doing so, but I think it starts with the customer and their expectations having shifted during the pandemic. I think we all thought this was the right model years ago, and telehealth has obviously been done for years now. But I think because of the shift in expectations, it shifted how the other stakeholders, including payers and regulators, have thought about the delivery of healthcare. And they've also come around to meeting and understanding what their constituents wanted. So I think we need to adjust on our side, and recognize that this is the model and this is where it's going. I would start with a focused approach and a use case that supports the array of service offerings that your organization delivers, of course.
I think for me, I know Adam said one thing, but it's really two things that come together. Use your imagination and be solution oriented. So it's start over, right? Don't let all the operations that currently are working or not working impact what that service looks like for the future, and don't be afraid. So use your imagination to clear the board and start over and say, okay, I'm starting a brand new telehealth practice. What does it look like, right? And then from there, make the trade-offs that are necessary and is optimal for patient care and provider satisfaction, and build it out by selecting one use case, by testing and scaling, right? You're not going to boil the ocean in one day, but over the years, you could continuously build to an extent where for us at New York City Health Hospitals and ExpressCare, any model that comes to us, we could quickly turn around within 48 to 72 hours and have a solution for it, right? And it's just incremental at that point in time. But from day one, it was having a viewpoint, having a decision that was made based on data, and being imaginative in having a whiteboard and building it all together in a blank canvas to what healthcare is built, meeting the patient expectation, not necessarily meeting the expectations of regulatory bodies and others, and then working backwards. I think if you start with the patient first and build it out, it's going to be quite successful.
Well, thank you all very much. I just want to let everybody know who's listening that this session has been recorded, and we'll be making that publicly available in the next week or so. And I want to thank you all for attending. It's always great to see is that the most of the people who joined the session are stayed on till the end. So I think that's a real testament to Chris, Erfan, and Brian for your insights today, and I want to thank you all for the work that you put into it. So with that, I will bring this session to a close and wish everybody a happy rest of Tuesday. Bye.